Welcome to East Minutes. Today we are going to talk about the GroinPain trial. As tension-free hernia repair techniques have become ubiquitous, we have seen drastic decreases in recurrence. Indeed, the most troubling complication of inguinal hernia repair is inguinodynia, a relatively common and difficult to treat condition. While there is some evidence that minimally invasive techniques may be associated with less acute pain, the incidence of chronic groin pain is independent of technique and occurs in about 10% of patients, with 1 to 2% saying their symptoms are severe. Both the pathophysiology and treatment of inguinodynia are complex. There are multiple potential etiologies of chronic groin pain, although neuropathic is likely the most common. Multiple techniques for therapy have been proposed, but there is little comparative data. The most invasive technique is triple neurectomy, where the ilioinguinal, iliohypogastric, and the genital branch of the genitofemoral nerve are resected. This is associated with a 60 to 90% response rate, but it is a technically challenging operation. Other approaches have their advocates, including a tailored neurectomy, wherein the nerve specific to the patient's pain syndrome is resected, as well as a non-invasive technique called tender point infiltration, which is simply injecting a patient's most tender anatomic location. The GroinPain trial, published in Annals in 2018, was an attempt to compare these two techniques in a randomized controlled trial. The RCT was a single-center experience comparing tailored neurectomy done by one of two experienced senior surgeons to a series of tender point infiltrations at 2-week intervals. They included adult patients who had ongoing pain more than 3 months after open Liechtenstein repair. These patients were also required to have a 50% reduction in their pain scores after an initial diagnostic TPI. The authors excluded patients with recurrent hernias, signs of local inflammation, and those with unreliable follow-up. The power analysis was designed for a 0.10 type 2 error and yielded a 54-patient total sample size. The study design included randomization after index intervention, and then in-person follow-up at 2 weeks, online follow-up at 3 months and 6 months, and a final in-person follow-up at 1 year. The primary outcome was successful pain reduction at 6 months, with that being defined as a greater than 50% pain reduction measured by an 100-point VAS scale. Secondary outcomes included complications, change in employment status, and overall neurophysiologic status at 1 year. The study did allow for a crossover from TPI to neurectomy if TPI was not successful at 6 months. Of note, the study ran over 7 calendar years, but they successfully recruited their 54 patients, 27 in each group. 5 total patients were removed for incomplete follow-up or incomplete data sets. 19 crossed over to neurectomy after TPI failure. Baseline VAS scores were similar in the two groups. At 6 months, TPI was successful in only 22% of patients, whereas neurectomy was successful in 71%. This was statistically significant. Of the 21 TPI failures, 19 agreed to cross over to neurectomy, and there was a 58% salvage success rate with delayed neurectomy. Importantly, patients who had success with TBI had lower baseline VAS scores than patients who underwent neurectomy or those who had a failed TPI. Complications were uncommon and minor in both groups, although slightly higher with the surgical technique. No patient went back to work after successful TPI, but 4 patients returned to work from disability after neurectomy.